Hey everybody, welcome to Peer-to-Peer Academy on this beautiful Wednesday night in November. I am Nick Bruns. I'm joined to you by my good buddies down in Florida, Brian Szabo and Eric Fazio. Yes, we are wearing our respective football jerseys today. We're keeping it casual, but we got a heated race in the NFC, so I got to represent.
Yes,
Yes, I'm
we
in
do.
Milwaukee, but don't call me a Packers fan. Brian, you're the Packers fan here, right?
I'm a Packers fan from Pittsburgh, Nick. It makes no
Oh,
sense, but we got a big game for Thanksgiving Day, so I can't wait for it.
And Fazio, you're repping the Tampa Bay.
I'm a homer. Yeah, we're in Tampa, so I'm a Buccaneer, and haven't been that my whole life. I started off a Bills fan because I was born in Toronto, so they kind of share that
Yeah,
venue sometimes. So I grew up kind of a Bills fan, but then once I moved here, I switched pretty strong now. Pretty strong. We
we'll
just
see
lost
you
to the
guys.
Bills, so
Yeah, that was a rough game for you
that was
guys.
a rough game. Good game. Good game. Technically, but yeah, rough game.
Well, we could talk football all night. I mean,
All
honestly,
day.
how many
All
hours
day.
you guys got? We could keep talking
I
football,
love
but
football.
I'll spare you my opinions. I'm a little bit biased towards Detroit, but I'm gonna spare that. We'll talk again in January once we see you guys in the playoffs. We're here to talk about the light adjustable lens, and this format it's meant to be interactive. So everybody watching, I really encourage you guys to reach out, ask questions. We really want to interact. But we're going to go through a lot of the FAQs, a lot of the stuff that the three of us here, as doctors treating patients involved in this world every single day, all the common questions. We know that there's a ton of them. We hear them all every single day. So we want to navigate those. We want to talk about them and make sure that mixed messages aren't being sent and that people who are curious about either doing this as a physician or getting this done as a patient or both um, understand, what it is and how we do it. So let's get started. Brian, I'm gonna start with you. Can you talk to me a little bit about why, I mean, the LAL is just a monofocal lens, right? So if
Mhm.
it's a monofocal lens, we already have monofocal lenses. We're pretty good at doing monofocal surgeries. What makes it different? And why is there even a reason to have this type of technology?
Yeah, I mean, the biggest thing, Nick, obviously, is the adjustability of this lens. So there's no other lens on the market where after you put it in after surgery, you can go back and adjust it. Right now, with we have amazing lens calculations that can, and Eric, you guys know this very well. But the lens calculations really only give you a perfect result about 83 to 87% of the time right now. So there is like a discrepancy in that calculating a lens target, picking the right lens, and putting it in the right spot. And a lot of that has to do with something called ELP or effective lens position. And Nick, I know you and Dr. Vukic talk about this all the time.
Mhm.
You can't quantify that variable. You can't predict where that variable is going to end up. So basically, that means where the lens is going to sit in your eye. Does it sit a little bit forward? Does it sit a little bit backwards? And the way you can kind of combat that problem is using an adjustable lens because, hey, if it's sitting a little bit out of place, we can just adjust it and move it and change it to give you better distance or better reading vision or a combination of both. So the adjustable lens is not just a monofocal lens; it is far superior, far more than that. Which is why we're always talking about it. We love putting it in our patients.
Eric, what do you think? What's your take on that question?
Well, Brian hit a lot of it. So when you talk about fixed position lenses, you got to talk a little bit about stats. So I was lucky enough to be in a lot of the research trials, and we were doing a lot of other research with fixed lenses. And he's right, about 83, 87, somewhere in there is about where you hit it. Where patients are happy, you hit your target, they got perfect distance or perfect near, or combination of both. When we started doing the trials, those percentages jumped by 10% plus. And that was insane. Like you don't see that kind of jump. Like, you would argue 1%, 2% was a big deal back in the day. And this has started in 2012. So this is a long time ago. And we just got so amped and so excited to start seeing those numbers just hitting that accurately. But I guess to put it simpler, maybe for some of the audience, you can't predict healing. What we're talking about here is healing. So how the eye heals is a little bit unpredictable. So when the lens goes in the eye, even if it moves 1 millimeter, that's actually a significant error in the numbers. These small little things make a big difference in the eye, as you guys know, but maybe some of the audience doesn't know. So being able to adjust to whatever healing response you have is just huge, and especially huge in patients that have had prior surgery and have had the lens. of which I've done many, family members and tons of patients that have had refractive surgery, either RK or LASIK or PRK. It's just in those cases, it's the only lens I suggest.
Yeah,
And
that's
you
fair.
just to interject here, Nick, a little bit. I feel
Mhm.
Dr. Fazio, you just we just did your wife, right? Dr. Newsom did your wife's surgery, and we put the eye adjustable lens in her, right, Faz?
Who, Tina?
Yeah.
Is she married to me?
Last
So
I
my
checked.
wife, yeah, so my wife had her second LAL done today.
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 Okay.
Today.
So good
So
question then.
so
Follow up.
there's a
Go ahead.
lot of, yeah, I didn't tell you, Nick. So let's see how this
I just,
comes in here.
yeah,
Uh
I'll tell him. Don't worry.
so Tina's right here. So Tina, here's her name, and she's
There
popping her
she is.
head here.
Hey.
You can see her
Hi,
little
Tina.
her little glasses. My wife Tina. So a little
How you
bit, because
seeing?
I know Nick, this is kind of cool to kind of do this, and when you do it
Yep.
on your own family members, obviously my lovely wife here, you trust technology, number one. Funny
Yep.
enough, she's in the OR. Her sister-in-law is next to her, who's at RK getting an LAL. And then the head nurse's husband was there as well, who's a pilot.
Oh, wow.
That
Okay.
tells you a little bit about why you recommended. And she's had LASIK. She's had hyperopic LASIK, Tina has. So you can see she's wearing the glasses, being a good girl.
Looking good. I love it. Looking
There's
good.
some questions, we talk about, but like, did you drive today?
I drove today, yes.
And she picked up my kid today. So we obviously, that we could talk about that, and we can talk about a
Sure.
bunch of different things and talk about how she's wearing the glasses and what's going on. I'm not going to hold her here to do that.
She
Thank
has
you.
to wear a jersey. She
Are
has
we
to wear a
done?
jersey.
Yeah, you gotta
Yeah.
wear
We're
you need your
done. We're done.
jersey.
Thank you for popping in.
Okay.
Congratulations. Hard part's behind you, man.
Yeah.
She's loving it already. So,
And big question, Eric, are you doing the adjustments?
yeah, of course. Definitely.
All right. All right. So
100%.
you guys hit on a good point already. I mean, the effective lens position. So the stat you said, the number you said, 1 millimeter. The rough math works out 1 millimeter equals 7% of the power of the lens, which ultimately, if you have a higher powered lens, if you're
Yep.
more farsighted, that means more of a refractive error. So that's why, especially people who have sometimes higher prescriptions can end up more off the mark because the lens can be shifted. There's more room
Yes.
for it to move. Now, your wife, she had hyperopic LASIK. That's a
Yes.
completely different wrinkle in this whole equation. It makes our numbers and our math just really less accurate, right?
Oh yeah. Yeah, I should have brought Tina's corneas here, but the maps, it's not just, yeah, for her, she's got that almost that conus look with an oblique astigmatism. But fortunately, even in the early refractions, guys, that was the first eye we did was her worst eye. She's gonna hit 20/20. She should be fine. Again, to Brian's point, we use this lens like crazy. So, we're doing 1,000 a year past 5 years. We've done a gazillion hyperopic LASIK patients and myopic RKs, just more than I can count. So I've got a good feel on how do you work with these and what's your success rate, and insanely confident about what the lens can do. And also, how do you talk to the patient about expectations and what do you do? I feel very comfortable in my skin doing that. And I think that's important, as a provider and for a patient hearing that, they want to hear that kind of confidence and what are the expected results. And can you talk to that with experience, I think is key.
What was one of my next questions, and I think we already kind of answered it, is if you had LASIK, does that
Yeah.
affect your decision to do the LAL? And it sounds like it's a great choice, which it is in our practice too. That's
Yeah.
really the only lens I would do.
That's
Brian,
something
why
we
would
would do
you?
as well, Nick.
You're a young, good-looking guy, Nick, but I hate to admit it, but I've been around 30 years. So the problem is with me is I've seen all the other stuff, right? So
Yep.
pre-LEL, we had to deal with these people. We had to deal with patients getting cataracts. And if, there's a guy in Tampa, I've talked about this before, but he just thought he's going to fill Raymond James Stadium with RK patients. So he just cut on a gazillion people.
Okay.
So Tampa is a target-rich environment for refractive surgery. Plus LASIK, we have some very alpha LASIK personalities historically that did a gazillion cases of LASIK. So really both are around here, but RK as well. Again, Tina's sister-in-law had RK, and she had surgery today. So that's and her best friend had RK, and we did her, and she was actually we presented her in the Academy of Optometry, and she won an award for that case. It's a very interesting
Awesome.
case, which I'll show you. I'll share that with you. Very cool case. But anyway, it's really incredible, like what you had to deal with before and the errors you'd get. I mean, the argument, probably the stat, not the argument, the stat you hear in ophthalmology and optometry is about 1 in 6. You're gonna really F it up pretty bad.
Hmm.
I think 1 in 20, you're still messing it up, but you're not messing it up as bad. Like over a diopter, like you're off. Like they're definitely wearing glasses full time. That's not a good statistic. When you're looking a patient in the face, you're going, yeah, you're going to wear glasses again, and they're used to not wearing glasses historically. Uh, not a good thing. With the LEL, those numbers flip almost opposite. It's just incredibly accurate. You can get them largely out of at least distance classes, high 90s, percentages. That's just unbelievable, the difference.
Yeah.
And the other reason, guys, you also use it in post-refractive patients like post-LASIK or post-RK is because if you are off, say you use a fixed lens and you are off on your calculation, or the patient's just not happy with their vision and refractively there's some MRX left over, like what are you going to do again? Are you going to do another enhancement over top of their LASIK they've already had? You can't do an enhancement or LASIK over top of RK. You know what I mean? So, I mean, there has been times when you can do a PRK enhancement over top of an old LASIK flap. We tend to do that sometimes. But if you're missing the mark and you're trying to use other ways to kind of fix these patients, it becomes very difficult. So if you just
Yeah,
do a
so another
one
wife
done,
in the background.
oh yeah,
Hi,
there's
wife.
Ashley. There you
Ashley.
go, Ashley.
Hi, Ashley.
But if you do an LAL, you don't have to worry about that because you can adjust them afterwards. So you don't have to worry about a second
Yeah.
surgery again after the LAL.
Yeah, Dr. Newsom jokes about this. So before Dr. Szabo was in diapers, but when we started doing adjustable cataract surgery, adjustable, you know what that meant? It meant doing LASIK over the top of the
Really?
cataract or exchanging the lens, which is semi-crazy and very risky to do. But we did adjustable cataract surgery, to your point, Brian, which was not easy, and not truly adjustable. It was just trying to fix the mistake. And sometimes you couldn't. You'd have the dry patient, you have this, you have that complication. You're going to cause haze hitting it that already been enhanced, God knows how many times, and you're messing with that cornea. It's just not an option.
Yeah, I think that's the common misconception is that, I've had that conversation with patients before talking about a fixed lens and then, well, you can just do LASIK if you miss your mark, right? Well, we can, or we can do PRK, but that is compounding surgeries. And generally in medicine, we don't like to do more surgery if we can avoid it. And even with LASIK or PRK, you're relying on the cornea to heal itself in a way that is predictable. And we already missed our mark, so something in your eye already was unpredictable. Was to say it just seems like it's a bad idea. So I don't always like to have that in the back. When I tell patients that we're doing a surgery, this is a one-time deal. We're never planning on going back
Yeah.
unless we absolutely have to. And can we sometimes? Sure, we can sometimes, but that comes with a different conversation.
Yeah.
Nothing is 100% either.
No.
Even with the LAL, it's really close to 100%, but it's
Yeah.
not 100%. No
Right.
surgery is 100%. So I tell patients all the time, if you ever hear a doctor say anything about guaranteeing anything, run the other way. There's no such thing
Yeah.
as a
Leave the
guarantee.
room. That's what I
We're
tell
hedging our bets. We're definitely trying to play the odds and work them in our favor as much as we can, but nothing is a guarantee. But we're controlling variables. That's what we're doing
Yeah.
with the LAL. We're controlling variables. So let's talk about the process a little bit. The most common question I get, probably the most common question, is about those awesome glasses that your wife was wearing. Can you talk
you.
about how you have your patients wear those glasses, when they have to wear them, when they don't have to wear them? We know what the label says. It says 24/7, but
Yeah, sure.
Right.
It does. It does. So that's funny. I made her come in here with those on because I wasn't sure how, I wanted to take that. But it's dark here, so she's immediately got them off. So if that's a good question. If it's dark out, uh, she's not wearing those glasses. That's just
yeah,
not happening. Showering, all this, so I have a window over there. She's not wearing those glasses. If she's inside and we have a fairly good blind system and the blinds are drawn, she's not wearing those glasses. She's taking a break. She's maybe wearing cheaters before the first adjustment because that's, a little bit hyperopic where we initially target if we can get lucky enough to hit there. She has hit there, so she can just wear some cheaters for reading temporarily. Distance is already pretty good. She's driving without glasses. Uh, Now, for going outside, walking the dog, doing things like that, she is wearing her glasses. She's wearing the Yark sight. Bit of a misconception there is the UV protection is equal between any pair of the glasses. You do not need to necessarily wear the dark pair going out. If you accidentally walk outside with the clear pair, you're fine. I'm sure you've heard that, Nick.
Hmm.
They're like, oh, I didn't wear my dark glasses.
Yeah.
Yeah, the UV protection is 100% the same. It's clear. It
Yep.
is not tinted. The tint is for comfort
Mm.
only.
Right.
Um, but that's kind of where we're at. And, if you're at a station, you're in your office, we have a lot of very active people that get surgery and try to get back to work, get back to their computers, whether they're working on site or they're at home. They're just more comfortable sometimes in cheaters and stuff like that. And, we encourage them to do that as long as they're just making some protections against UV exposure.
Yeah, anything to add, Brian?
No, I mean, the other thing, I mean, Fazio hit the nail on the head. I mean, the other thing too, it's a great marketing strategy for RX
Yeah.
site and our practice. You know what I mean? So these classes, they're conversation starters. People, they wear them to dinner, they wear them out on their walks, they run into other people. Like, what are those glasses? What is that RX site logo on the side? And it gets you talking. You know what I mean? It gets the patients talking. Like, oh my God, there's a lens that can be adjusted. Like, that's amazing. It just builds up that kind of momentum or that kind of conversation about the lens, which is really cool, in my opinion. That's probably the only thing I would add to the glasses discussion. Fazio hit the
Yeah.
nail on the head.
The funny story, and I've told this story before, but I had two patients who I did adjustments on at different times. I had a guy going through it, and he's like, I met a woman, and she saw my glasses, and we started a conversation because we both had that in common, and I was like blown away. So I was playing matchmaker, really.
Yeah.
I'm like, you guys have this most super unique thing in common, and I am like at the center of it. I feel so honored. And so if you get married, if things work out, I appreciate that wedding, right?
Yeah.
I think it lasted one date, maybe. I asked him about it. He's like, it wasn't. Oh, shoot.
They were too particular. I'm sure both patients were very particular.
Yeah, they might have been pretty. They were.
Like things a certain way.
Yeah. But the glasses, I mean, that's a big thing that we hear about, Do I have to really wear these glasses all the time? No, you don't. You really don't. The FDA label was written for the previous version of the lens that didn't have something called active shield. So active shield is like a redundant coating on the lens that protects it from environmental light. So in normal room conditions, you're getting enough coverage. Now, what we don't know, or at least I don't know exactly, is how long an active shield lasts. The other question I get sometimes is, well, if we get to a good spot, do we even have to go through the lock-in process? You do, because active shield at some point does wear off. Now, how long is that? I don't really know, and I'm sure somebody does. I don't know. I'm not a polymer scientist. Generally, though, we want to be done with the adjustments in about 6 months. That's just kind of our guidelines. But
Yes.
if you walk to the mailbox, you forget your glasses, did you really ruin everything? No. It's just a cumulative amount of UV light that you're exposing yourself to. We'd prefer you don't, but did you really mess something up? No. Now, don't get on a sailboat in the Caribbean for 3 months and not have your glasses on. That's a different story. That probably will do something, but we
Yeah,
prefer to.
we have seen that. Yep. Here
We've seen that.
How'd it go?
Yeah, not good. Had to
Not good.
explant the lenses. Yeah.
Okay. Yeah.
That was before active shield. Yeah.
Okay.
But yes.
Yeah.
But yeah,
So the lens
does
can be
happen.
warped. And, there's only one thing to do at that point. Let's take the lenses out. Now, Brian, how do these lenses, have you taken one out before ever?
So yeah, so I mean, they definitely once you have them locked in, they're a lot easier to take out, like before you do an adjustment. Or then that happened one time where we had kind of a miscalculation, and the patient actually had their contact lenses on during our topographies, and we didn't realize, and we actually were off a couple diopters on the lens. So very easy to explant a silicone lens before you start doing adjustments, especially before you lock in. But it seems as though every time you do an adjustment or a lock in, that lens gets harder and harder and harder. And the problem is when you go to take it after a lock in, sometimes that lens can shred like glass a little bit, or it can break like glass. And you really got to be careful to get all the pieces of that lens out. So you're hoping, when you put this lens in, you don't have to take it out. Very few times are we explain these lenses, but it does happen. But it can't be taken out. No problem.
Yeah, we've taken out very few, and they're very strange circumstances that we've taken them out for. I can tell you that for a fact, we've taken out way more other types of lenses than we have the LAL. I mean, I can count on one hand how many LALs we've taken out of the thousands that we've done.
Yeah.
They are difficult to come out. And again, we don't ever intend to take them out. So when we make this decision, we're kind of trying to future-proof your eyes. We're trying to get you to a spot where you won't need cataract surgery again. Now, we can't guarantee that something else won't happen, right? We can't guarantee that you won't get macular degeneration. We can't guarantee that your eyes won't, change over time in an unpredictable way. There's always things that can happen. But, the one thing, again, people tend to try to look for a guarantee, and I can't guarantee anything, but I do expect things to stay very stable over time. There are two things that dictate what your glasses prescription is going to be. Number one, it's your lens, which is now synthetic and it's in a fixed position. And then number two, it's your cornea. Your cornea changes until about age 30 in relation to the length of your eye, but that pretty much stabilizes. So once you get to that certain point, there really shouldn't be any refractive shifts unless you develop some sort of change in your cornea, which would be unpredictable. But again, controlling the variables is really what we're trying to do. I tell people too, same thing with the glasses that you mentioned, Fazio, is the UV light, the clear ones and the tinted ones really do the same thing. There's really not much of a difference between the two. It's more for comfort than anything.
Yep.
Let's talk about the adjustment process a little bit. And Eric, I want to pick your brain a little bit here.
Sure.
We had a question come in. I'd like some commentary on this approach. So using the first LAL adjustment to correct astigmatism, landing on the right spherical correction, and then using contact lenses to trial certain outcomes. Do you do that? Is that something that you do normally in your practice?
Depends on the patient. So let's give a couple scenarios. So let's say I had a patient today, I did 8 adjustments today. So we had a patient today that had a history of monovision, right?
Mhm.
Very comfortable, pre-discussed expectations. I didn't do that. Just
Mhm.
just move the patient into a mini mono. We do not go aggressive, even in those patients, because sometimes they may have been used to a 2 or 2.5 diopter disparity, but you can get the same vision with 0.75 or 1 and they still see better in the distance. So I still will move them into a mono position without that. If there's any question, and we have a kind of intense questionnaire that we talked to them about where they're worried about depth perception or something like that, or they're not used to that, they've checked that they've never tried monovision contact lenses, never done that, then we will target distance initially, usually, and then you can trial lens trial or contact lens trial. The most successful will be the contact lens trial. I've found with, my significant experience. It's just a bit more time consuming, so I don't use it every time. I've kind of got, I feel like, enough experience so I can get away with just trial lenses, but
Mhm.
I still use it. So if I have that patient, I'm like, they really are pretty picky, and which I don't blame them. They're paying good money for the technology, and they really want to know, do the contact lens trial. Makes a lot of sense because it really is a good real life example of the disparity. And if there's going to be a problem, I feel, with putting this lens in and a patient being unhappy, it is usually the disparity in expectations that do it. It is those two things that drive this. Either they expected to see everywhere like a 20-year-old, and that's just an expectation thing, or they don't really like the disparity, but they still want the near vision. Um, we're very careful about how we educate and explain those options, but sometimes it's heard, not heard, what a patient hears doesn't,
Mhm.
we're all going to run into that. But if you're a provider listening, it's very important you set that table correctly to get a happy patient. I
Yep,
don't know, I
that's
kind of answered
exactly
a
why
couple
we're.
questions there, but I don't know if that was kind of
Yeah.
sort of answering that. But yes, it's a good idea. If you have the time, do it. If you're younger into it, do it for sure, because you're just going to get confidence that way. And there's nothing wrong with being slower than faster with this technology
Yeah, I agree.
initially.
Especially early
Yeah,
on. I was
especially early
doing,
on. Yeah.
yeah. Once we were, because there is an art to this. I mean, as you both know as well as I do. There's an art to this. It's a science and an art.
Mm.
But understanding, from a provider point of view, what the lens can do is important, and that's exactly why we've got this platform here to try to educate both doctors and patients and set expectations. That is the most critical part in this whole thing. That the laws of physics, they still apply.
Yeah.
I didn't write them, but we got to live by them. So what that means is, if I give you better reading, something's going to compromise. It's
Yeah.
either going to be your distance quantity of vision or your distance quality of vision. Something is going to give up.
Mm.
So other lenses on the market, multifocals, extended depth of focus lenses, what they what they lack is a true accommodative ability. That's what your natural lens has. You're born with a lens that's flexible. It can accommodate. And over time, that flex kind of goes downhill, and that's when we start to develop the need for reading glasses, and then subsequently a cataract. So we don't have a lens on the market yet that has full accommodative ability. We're working towards it, and whoever figures that out will make a lot of money, but we do not have that yet. So what we have is this, and this is pretty darn close to that, but we still have to kind of cut corners a little, and we do that by what you mentioned, blended vision.
Yes.
Now, with the lens, because it is a little bit more aspheric in design, you don't have to go as far as you would with a contact. And that was my first thought right away when we started
Yeah.
doing this. Well, let's push everybody to -2 in the
Yeah.
non-dominant eye, which is way too much. -2 is that's a huge disparity and just not necessary because people still may have the demand for more reading vision, but just moving that one eye further, it's not a linear improvement in near vision. You're now creating more anisymmetropia. You're losing depth perception. Um, but what you can do is sort
And
of,
actually, Nick,
yeah.
that's one, excuse me, I'm sorry, just to,
Oh, go
to
ahead.
chime in there. That's one of the craziest things we see from other practices in the area. Whenever we see a patient who's coming over from, they got their surgery done somewhere else, somebody who just started using the adjustable lens. And the biggest thing is that they jump their disparity very quickly. Whereas,
Mhm.
we've been doing this since 2017, in the FDA studies, we learned very quickly and we were taught very quickly that you do small increments, right? So that reading vision, you always get distance vision first, or else the patient's going to hate you. But then you kind of bring in that reading slowly. And a lot of times we see problems from other practices or in other patients is that their first adjustment was a plano -2 or a plano -125, and they've never had that before. That's okay to do if your patient has a history of monovision with monovision contacts or monovision LASIK. That's okay because their brain's used to that. But if you have like a virgin eye, it's never, or a virgin brain, it's never dealt with that monovision, it's very difficult to jump somebody and then for them to be okay. So we always say like get distance, then go small increments of near, and then let the patient try it before they buy it with a contact lens if you go too far. So that's a huge point right there.
You're like skiing down a double black diamond right away. If you've never had that, I mean, you're jumping
Yeah,
to the double blacks right away. It is a
right.
jolt. So yeah, like you
Yeah.
guys do. I mean, my first adjustment typically is -50 to 75 on most
Exactly.
everybody.
Yep.
And a lot of times that's sufficient. That really ends up
Mhm.
being sufficient because what happens kind of over time and the really cool part of this journey is, well, we have to remember that we're not just treating eyes, we're treating the entire visual system. And neural adaptation is a very real thing where the brain learns to interpret new things over time. Some people neuroadapt slower, some people neuroadapt faster. Everybody's just a little bit different. But starting with just a little bit more of a conservative approach and then moving in that direction at about half diopter increments, on average, we're at -1 to -1.25. Rarely past that. And usually I only go past that if they do have a history of monovision and they're just used to that. Um, so when I use contacts, I really don't that often. I really don't. I just don't find the need to. But I will pull them out on my third adjustment. If we're at a spot and we haven't quite hit our target and we're still trying to
Mhm.
make a decision,
Yeah.
that's when the contact lenses come out because we only have one more arrow to shoot and I want to make sure that we're getting it right. And so that is when I will use the contact lens. And um, it also depends on the patient. I got to make sure that the patient is comfortable with the contact lens and I trust that they can wear them. I've done contacts before and I had, people come back and they're complaining about the contact lens feel, which is not the point. The point is the vision simulation. It's
Yeah.
not the feel of the lens.
100%.
So we want
Yeah.
to make sure that we're still setting that same
100%.
target,
Yeah. Good answer.
Yeah. Okay, I got another question that came through, and this is kind of a long scenario, but I just want general guidelines. So somebody said that they had the surgery done for all the reasons that we've already talked about, the adjustability, the customization. Dominant eye set for distance, and then about 4 days after surgery, the sight started to degrade and has not returned. No longer have the amazing distance vision. Now, this is only 4 days after surgery. Any advice for this patient? They're starting to have a little bit of a glary kind of situation. It sounds like some halos, starbursting. Thoughts
So
on
I
that?
they've
mean, this
not, yeah,
this
they've not
segment,
had any adjustments just 4 days after the actual surgery.
I don't believe so.
Yeah, so what typically happens in those cases, because you'll see that with fixed lenses too, and you guys have seen this too, when you get that myotic rebound pupil and the vision is great, and then the pupil starts relaxing and kind of gets back into its normal movement. And it's normal to not have, just like with my wife, the best vision initially because you've not done an adjustment. This lens is not perfect out of the box. The astigmatism has not been adjusted at all. The lens is spherical out of the gate. meaning it doesn't have any astigmatism adjustment. And most patients do have some amount of astigmatism, again, including my wife. So she's not perfectly 20/20. When I measured her first eye, she's about 20/40. So when you have an uncorrected amount of in your eye that you don't have 20/20 vision, whenever you look at a light source or anything like that, it's normal to have some flaring of lights, just as if you don't have clear vision. The thing will tend to blur out and flare in an unpredictable fashion. I doubt anything's wrong. It's probably just you settling in and the pupil kind of doing its thing. But it's not a bad idea to go in and just make sure the pressure in the eye isn't high. You could probably get checked in, and just make sure nothing's going on with the health of the eye. But I doubt it.
I would also, just to add to what Faz is saying, totally right to get a surgery, but also too, if you're going along and you're doing your adjustments and things just aren't quite right, or you're noticing more glare, or hey, the vision's a little bit hazier than it was before. I mean, an early YAG is not a bad idea. Also, just get that scar tissue or that posterior capsule out of your way, and just kind of decrease, your variables and things like that.
So
It
I want
looks
to
like,
add more. There's
yeah,
actually more to the story that I missed. So the complaint, they've actually had two adjustments.
Oh, okay.
Left eye is set for reading, right eye is set for distance, but there's a lot of variability in amounts of light. So outdoor
mhm.
light versus indoor light, and a lot of light scatter that comes with that. Any thoughts with that
Yeah.
additional piece of information?
So I've been kind of reading this question as we went, guys, a little bit. So yeah, if you've already had the YAG, you've already had a couple adjustments, and now the light conditions are affecting the vision. I would do something. So there's probably something wrong with the pupil, like Franz was saying. Not wrong, but maybe the pupil is a little bit. It can swell or get smaller at different points on different people. And sometimes when that pupil really widens out, a lot of people get a lot of glare and a lot of light scatter. There's actually drops that we use in clinic that can actually constrict your pupil and kind of stop that pupil from stretching out wide and allowing a lot of light in to scatter. So that would be my go-to. I think Murray's the one asking the question. I would use it's like a product. It's new, Nick. I'm sure you guys have it up there. It's called Viz.
Hmm.
It's a really nice pupil selective miotic. And it's something that I use after my ICL surgeries. I use it after my LASIK surgeries. If anybody's complaining of that nighttime glare halo, and even in our pseudophakic cataract patients, we've been using it a lot to kind of cut down on that glare. So Murray, that's something I would ask your doctor about. Is there a pupil agent that he recommends to try to shrink that pupil down, let a lot less light in, and see if that fixes
Yep.
the problem?
And we
Yeah.
just got samples of Colosian now too, Brian, and
Mhm.
sometimes even just good old Alpha Gan works, which is an oldie but a goodie, but good
Yeah.
points. Yeah.
Great
Yeah, we
points.
have.
And
Yeah.
big thing you mentioned too, ask your doctor. I want to make sure that that's crystal clear here too.
Yeah.
What we're
Yeah.
trying to do is not give medical advice, but at least
Right.
give you some guidance.
Hmm.
Your eyes are unique to you. We can't see them from a computer screen without a camera that looks inside your eyes or at the cornea or the specific. So make sure you ask your doctor. But Brian, fantastic point because that's exactly what I was thinking too. A lot of times it does have something to do with pupil size. Higher order aberrations. Higher order. So what are those? Let's talk about what those are exactly. We have low order aberrations, which are things that we can correct with the phoropter. The phoropter is that big black thing. We ask you one or two, two or three. That's nearsightedness, farsightedness, and astigmatism. Those are lower order aberrations. Higher order aberrations are things that we cannot measure with that device, and we measure with something a little more sophisticated called an aberrometer. Those things are spherical aberration, coma, trefoil. They create things like starbursting, halos, and just general glare, especially in low light. And they're worse in low light. Now, why are they worse in low light? It has everything to do with your pupil being large. When you're dilated at the doctor's office, after you come out of your light adjustments, you're dilated. And why are you blurry? It's because you've got way too much light getting in, and your eyes are just way more prone to higher order aberrations. So we are fortunate to be at a time where we do have options like Viz or Closey. I mean, those two options I've used on patients for this, not only to cut down higher order aberrations, but to further extend depth of focus, which can help. A lot of times when we go through the light adjustable process, we're trying to maximize our distance and then get as much reading as possible. But if I leave anything on the table, it's usually the really close stuff. Because if we want to get the really close
Yeah.
stuff, we're giving up the distance. But we have pharmaceutical options now that really do help if you're the right candidate for it, and that can just further extend range just a little bit. Or yeah, like you mentioned, Alphagan, which is a glaucoma
Yeah,
drop that we've used for
yeah,
forever. It
that's
does
a
have a
big one
little
too.
bit.
And patients are always like, "Why am I on the glaucoma drop?" No, it's not for your glaucoma, or you don't have glaucoma. It's an off-label side effect, positive side effect in the situation. So brimonidine, alpha-GAN, like Foz was talking about, Nick, we were talking about, all great options if your provider doesn't have, the capability of providing something else.
Yeah. Can you tell me what, because we talked about a YAG. Can you explain what that is and why we would do it just for everybody if we're
Yeah.
not, just for patients out there?
Yeah, a YAG essentially is what happens after that lens is something called the capsule. So we do cataract surgery. I want you to think about it like it's the cataracts of peanut butter M&M. I'm going to make a window in your hard candy coating. I'm going to take the chocolate and the peanut out, and I'm going to leave that candy coating, and then move that LA adjustable lens into your candy coating. That's where it sits. It's called the bag complex or the capsule. After a while, that lens and the bag complex are touching, and that actually causes some protein buildup, or we call it in layman's terms scar tissue, and otherwise known as PCO, or posterior capsular opacification. So when that happens, that could disrupt your visual system, and that could actually decrease the vision. It kind of looks like, oh, my lens used to be clear, and now it's like I'm looking out of a hazy windshield, or I'm noticing more glare and halos at nighttime. A lot of times it's because you have posterior opacification, you have a little bit of scar tissue. So we take a YAG laser and actually disrupt that tissue and go behind the lens and accurately shoot that capsule away and shoot all those proteins away, and it becomes a clear optic once again. And then you never got to worry about that variable again, because once you do it one time, the posterior capsule's gone. So that's what a YAG laser would do for you. Anybody with any type of lens, whether it's a silicone lens like the adjustable lens, whether it's any kind of other acrylic lens, you will need it probably, my guesstimate's anywhere from 3 months after surgery to 3 years after surgery, somewhere in that range. Everybody's going to develop it. Everybody's going to need it done to get that clear optic back and get your vision back where it was after surgery.
Yeah, it's like clearing off scar tissue. I mean, it's not actually scar tissue, but it's kind of like that. When
Yeah,
we look into your,
buffing out the lens. Yeah,
you just polishing it. When we
yeah,
look into your eye, it looks kind of like saran wrap. I mean, that's kind of what it looks like. So imagine if you're driving down the road and you hold a piece of saran wrap on the windshield of your car, it's gonna make things look a little bit glary or kind of starbursty or halo-y. It's exactly what it is. It's a normal thing. So when
yeah.
I deliver that news to a patient, I always say, congratulations, we can make your vision better because this is normal. We expect that. If you didn't develop that, it would almost be a little bit weird, but we expect that to happen. Yeah, sometime in the first few months, sometimes not until 10 years down the road, but inevitably you live long enough, it probably does happen. It's not a complication. That procedure, I mean, does that procedure hurt when you have that
Not at
done?
all. So it's a very quick, like 10-second procedure. You don't feel it, you don't see it. It's kind of, for the surgeon, it's like a game of asteroids.
Yeah.
It's like a video game for me. So I love doing it. It's really fun. But no, there's no, post-op drops. There's no, process where you can't live your life after doing it. And Nick, we tell patients all the time, hey, this could happen before your first adjustment, in the middle of your adjustments, or 3 months to 3 years down the road from adjustments. Everybody's a little bit different how they heal and when that scar tissue comes.
Yeah. Yeah. Great. Let's go back to the, there's a question actually about Viz, and I know this isn't really a Viz thing, but how long would you have to use Viz? How long after you use Viz would the pupil go back to normal? Or let's do that for Viz and closely. Any commentary on that?
For me, I mean, Viz is interesting. I don't know if you've used it a lot, Nick, but it's fairly aggressive. I feel it's more aggressive than the Colosi, so it really gives
Hmm.
you that little pinpoint pupil. It's going to go back the next day. I mean, your pupil will be pretty much back to normal. The Colosi is going to be the same, but it gives you a little less aggressive of a pinhole effect. Probably I'm starting there with the Colosi more than the Viz, you know.
Hmm.
And if they like the
And not,
Colosi, I'll move
yeah.
into the Viz to see if I get more depth and it doesn't bother them.
Mhm.
More in nighttime situations because it can restrict a little bit of that nighttime vision with that
Hmm.
little pinhole pupil that they have.
Mhm.
It improves the halos and all the aberrations you actually very eloquently laid out. I thought that was a really great explanation of those because they can be very confusing to understand
Hmm.
what those aberrations are. That was a good explanation. But it really, they, almost to the person, it helps them with those things.
Do you want to add something, Brian?
No, I would just say usually, I mean, I'm much more, Foz is more Colosi. I'm much more, I go to his Viz just because it's pupil selective. I like that it's not going to hinder any other parts of the eye or rotate the ciliary body forward or contract the back of the retina or anything like that. But usually, in my opinion, it lasts about 8 hours or so. At least that's what the Viz people say. So I would say generally, one drop can last you about 8 hours.
Yeah, that's about right. I mean,
Mhm.
they have different, I mean, pupil constriction, there is a limit before it starts to become counterproductive. Viz kind of walks that line pretty closely. Your pupil does get really, really small with it. And so I have had some patients say that they do experience dimming of vision.
That's right.
Closely, not so much, but with closely, you're not getting as small of a pupil, so maybe not as much of an effect. There's different flavors for different people,
Exactly.
and I think it depends. I mean, there's room in the sandbox, I think, for both products.
Yep.
There is an application here, though, I think, and I've reached towards those, more often than I thought I would. Again, because what we're trying to do is provide that independence of glasses. So when I always, it's interesting how my career has kind of progressed. I used to think we had two ways to correct our vision. It was glasses or contact lenses, and I wasn't really thinking of refractive surgery. Well, we have this third bucket of refractive surgery, and light adjustable lens is refractive surgery. And then now we have this fourth bucket of pharmaceuticals. So there's really four things that we can do. And combining two different things together to really keep people out of glasses or contacts it's kind of cool how we can do this and how there's an art to this.
Mhm.
What about this? So another question that I've got, never had dry eye before, but all of a sudden after surgery, I've got eyes that feel kind of scratchy or my vision's fluctuating, and then it seems to be getting worse. Any thoughts on that, why that is, or how we can help?
Well, it's very normal when you do have surgery. And again, I hate to keep throwing Tina under the bus, but with Tina, she's feeling the incision a little bit. Not a lot, but there's a little tiny small incision that is made into the eye, usually two of them. And, the eye is extremely sensitive. It can feel a piece of dust or a little piece of air touch it. So when you do have surgery, that's normal to kind of feel those incisions. The good news about cataract surgery versus, let's say, LASIK, and I hate to throw LASIK under the bus, but LASIK's a fairly large incision. It's that good old beer can incision. And there's a lot of nerves that are affected in that kind of procedure. When you look at cataract surgery, not so much, and especially with the LAL, because in many astigmatism procedures, and a lot of people may not know that, listen to this, there can be these incisions that are made to correct astigmatism. Well, that doesn't happen with the LAL. That happens inside the eye at the lens when you correct the astigmatism. So there's no cuts that are made really on that cornea for the astigmatism. Those cuts can be pretty big and also can add to the drying. The other X factor here is, of course, the drops. We know that there are necessary drops that are taken to prevent infection, prevent inflammation, and a tapering schedule for cataract surgery. That is also extremely normal. And these can be quite irritating to the surface and produce increased drying. So those are also usually part of those side effects. And you just got to balance that as much as you can with the patient. I'm a bit of a dry eye guy, so we're using all kinds of different things, preserve-free tears. You might be using compress and cleaning wipes, saline rinses, different things for different patients during that process, maybe even medicated eye drops to really help them through and get through that with a successful outcome. But in most cases, cataract surgery, in my opinion, is not an extremely drying procedure because the incisions are very small. And most of those drying effects will get better as the wounds heal in a bit of time and you get away from the surgical drops.
Yeah. Anything to add, Brian?
Yeah, I would just say, I mean, as a surgeon, when you make that incision for cataract surgery, there's very tiny corneal nerves that you can't see with the microscope you're using. And you really don't know where those corneal nerves are on each patient. It varies from person to person. So when you make your little 2.5 or 3.0 millimeter incision, sometimes you're cutting those corneal nerves that you can't see. And you're just trying to make your incision so you can get into the eye. Sometimes those corneal nerves take anywhere from 2 to 3 to sometimes 6 months to grow back. They will grow back. Your dry eye will get better. In the meantime, like Fazio was saying, there's all kinds of different things we do to help that. But it will get better. Just get through it. It will go away.
Yeah. I have everybody, I mean, every single one of my patients is on a regimen of preservative free. Preservative free is kind of the key there. We don't really want to add preservatives to a cornea that's already a little bit more fragile. Yes, compared to PRK or LASIK, cataract surgery is much less of a drying procedure, but it still is drying on some level. And so, I mean, I've never met a surgeon in my entire career that says, don't put my patients on preservative-free tears. We always have tears. We're trying to stimulate equilibrium in the tear film. Um, but what happens when we're doing the adjustments? I mean, we're exposing your cornea to really high intensity UV light. And imagine going to the beach. No matter how much sunscreen you put on, you're going to feel a little crispy no matter what. No matter how many of those tears you put in, after we do a 2-minute light treatment on your cornea, which is, like you said, Eric, really, really sensitive, tons of nerve endings, it probably feels a little bit dry, a little bit scratchy. Your vision might fluctuate a little bit too. So I am pretty quick to reach for pharmaceuticals when needed. Quick steroid, pulse steroids are not something to be afraid of. We use steroids in eye care all the time, and if you've gone through surgery, you probably were already on a steroid. But also things, immunomodulators, neuromodulator eye drops. I do plugs quite a bit, or we do something called Lacrophil. I don't know if you're familiar with Lacrophil, but
Yeah.
we do that a lot. Amniotic
Get on
membrane.
my wife.
Did Lacrophil? Yeah, yeah, I love it. It's great.
Yeah.
But
You
what
got
that does is it just keeps, it's like plugging a bathtub, but with hyaluronic acid, which is
Yeah. I don't know.
soothing for the cornea. There's all sorts of things we do. And when I bring this to my patient, I don't want them to think again that this is a complication. It's not. It's a little bit of an expected, where your eyes are gonna feel scratchy, they're gonna feel gritty. I know that, some more than others, and some will tolerate it more than others. Now, sometimes I reach for the next level of therapy, even if your eyes don't feel dry. I get that a lot too, where my eyes don't feel dry. Why are you treating me with pharmaceuticals? Well, it's probably because we can't get a good refraction. It's because you have these little punctate erosions on your cornea, which come from dryness, and you might not feel them. And if you don't feel them, well, that's a different story because that's something called neurotrophic keratitis on a really, really low level. Not a good thing. You should feel them. And so
Yeah.
that's a reason why we may need to be a little bit more aggressive with therapy for dry eye.
Yeah.
But it is a common thing, and it's not something that we shy away from, but we do want to manage it. And through this
Definitely.
whole process, the key there is time is our friend. We don't want to rush things, and you still are healing from a surgery. Now,
Mhm.
most of the healing happens probably in the first week, but you still are healing, and we're letting that happen while we adjust and while we kind of, customize. But when I tell patients, what do you tell patients for how long it takes to get through the process? How long does it take on average in your clinic?
That's a good question. Ding the dong. So we typically will do, the typical 2 week delay after the second eye. So then when you're there, you're about 3 weeks out of the first eye. We'll do an adjustment. We'll typically do a YAG next, and then on average, probably three adjustments, two locks. So you're really looking at about close to 2 months.
Yeah,
Yeah, I'd say 6 to 8 weeks on
Yeah,
average.
you're
Yep.
about
that's
6 to 8
exactly.
weeks, and that
Yeah,
and that's realistic.
that's what
Yeah,
I tell
we don't
people
rush it
too.
either. We don't do
Yeah.
this. We're gonna be, crazy and go crazy. One of the big important things, Nick, and I probably can't say that enough, especially for you young doctors doing this, is the patients need time to process their vision and to process that little change. Which again, Nick hits on your earlier point of just doing little small incremental steps and not just try to blast it in there. Because when you give them a little bit of disparity and they like that in your vision, they are also neuroadapting to that. Different people are different, but for the most part, you give someone a week, that's a good amount of time for them to get a good amount of adaptation on board, process that, report the results to the provider, which is what's so cool about this patient-driven outcome. And then you can act on that appropriately. If you're really blasting it quick and doing like these double weeks, treatments, I'm not a big fan of that. I push very hard against that if a patient's pushing on me to get that done.
Hmm.
I'm not going to go for that 9 times out of 10.
Right.
Yeah,
And that's why I put the 6 to 8 weeks. I mean, really, we're doing weekly treatments.
yeah,
You could do the lock-ins 3 days apart if you're pressed for time. But generally, yeah, give the patient, like Foz said, give them that time to adapt, give them that time to try their vision out. And the patients like that because they feel like they're participating. They have a legit, end game here, and I love it or I don't like it, and I'm going to, change it when I come back in. So we generally say a week in between adjustments. If you want to do the lock-ins every 3 days, you can.
yeah.
Yep.
Yeah, I thought when we started this, like people weren't going to get on board with it because it took so long. But yeah, I say 6 to 8 weeks. I mean, it is 6 to 8 weeks. I mean, sometimes longer. Rarely is it shorter than 6 weeks unless
Yeah.
we,
Unless you're going all distance. You
yeah,
can get distance right at the gate, you know,
Yeah. There's
like
those
one adjustment,
exceptions.
2 lock-ins. Yeah, but if you're getting the full range of vision with this lens, it's
Yeah.
going to take 6 to 8 weeks.
yeah, you got to
The,
let that happen.
Go
Mhm.
ahead. The good news is, guys, I mean, for especially for the non-doctors listening to this, the first adjustment does a tremendous amount of the work. So what I always tell patients is like 60 to 80% is the first adjustment.
Hmm.
Because that's the astigmatism. That's probably hitting minimum distance, maybe doing a little bit of a mini blended vision. You're going to be very happy right after the first adjustment. The rest are kind of like tweaks, what I call little putts into the hole. Like you took a 40-foot putt and you're like 2 feet away, and now you got to just tap it in. But that first putt is a big one. And, patients are then visually very happy by and far, most of the time there for sure. And then, so the time is a little less painful. It's not like you're blurry, blurry, blurry. I'm only clear at the end. So I just want to be clear about that.
Yeah, that's what we set them, and you guys do too, I know, but we set them for distance right out of surgery. So the lens that we pick out of the
Yeah.
box is close. It's as close as we can calculate to a perfect distance outcome. It's never perfect because like all the reasons that we just talked about, we're always off
Right.
by a little bit. But we're trying to leave you functional so you can still drive, so you can still see out here. And then we understand that you'll need reading glasses for the short term. But I tell people after the first adjustment, that first adjustment's a big day. I love that day. And I love even more the second adjustment because when they come back, you can see that the smile is on their face. They're like,
Yeah.
holy cow, this actually worked. You got them. They believe it. Up
Yeah.
until that point, they had no reason to believe you aside from what we've told them. But they actually can see that the proof is in the pudding with that second day that they walk into our office. But from the day after their first adjustment, I tell them really try to put those reading glasses away. Up until now, I wanted
Mhm.
you to use them because I need you to be functional. But if we're starting to add a little bit of a blend, we're starting to offset the two eyes a little bit, put them away. Test yourself. The worst thing you can do is go back to those reading glasses and use them all the time because your feedback becomes critical. I
Yeah.
need your feedback as a patient. You got to tell me what we're doing with the second adjustment and then the third if we need to. Next question, actually, which brings me to a good point. Fourth adjustments. Have you guys done fourth treatments before?
All the time.
Oh yeah.
Yep.
Yeah. Yeah.
All the
And
time.
when would you need it and how does it work? What do you expect to get out of it?
I mean, so it's going to be when if you're doing a fourth adjustment, you have to kind of trick the machine into giving you another adjustment, right? So you are able to do it, but it is like your least likely adjustment to make a huge change. Okay, so those adjustment powers go, significantly down as you go from the first to second to third to fourth adjustment. So your first adjustment, you're always going to get the biggest bang for your buck when you're doing your astigmatism adjustment, your first kind of reading adjustment, and as you go from first to second to third to fourth, you're kind of using up all the gas in the lens. So your fourth adjustment, you're not going to hit as much, as you would have in your first adjustment. We do fourth adjustments all the time, Nick, and Fazio
Mhm.
can, reiterate this. It's just if the patient just wants that little bump, or they want that little bit more, and you show them in the contact lens, they really like it, 2 thumbs up, they come back in and say, I want this. You can open up a fourth adjustment and do it, but it's your last one. You can't do anything past that at all.
Yeah. Yeah, we do it every once in a while. I mean, it's not like super often, but definitely we do it if we need an extra quarter or maybe a half. But
Right.
you can't get much more
And
than that.
we kind of overshoot with the tuning. So you know what I mean. If you want like a half diopter, adjustment, we kind of shoot to like a full diopter, and you kind of end up in the middle, and you get like a half diopter, resolver outcome.
It's
So
like
you got
kicking
to
into the
overshoot it a
wind.
little bit.
Yeah.
Yeah.
Yeah, I hear you. Another question came back, and we kind of already talked about this a little bit, but why don't you walk me through your process? How do you work through the adjustment process targeting? So do you set your distance aim for plano, or do you ever set your distance aim for negative 50, or do you ever decide to go hyperopic? Walk us through the adjustment targeting.
Yeah, so I can hit that one maybe a little bit. So we go to a meeting every year, which is called ACOS, and
Mhm.
probably a couple years ago, some of the data presented there, which is usually the higher end practices, very smart people that have done gazillions of cataract surgery, said that some of the happiest patients actually for the dominant eye you target at plus a quarter, just 0.25. So we started doing that immediately upon hearing that. And there was some question, at the time with the adjustments, is it maybe drifting a little minus with the locks? Is there a bit of that going on? I don't feel that that's the case anymore. So that's what we do. On the dominant eye, we're targeting plus a quarter pretty much throughout all the way to locks. We've been getting a lot of success with that. In terms of the non-dominant eye, it depends. So it depends if we have a post-refractive situation or not. If we are in a post-refractive situation of RK or LASIK, we are not hitting a near target on the first. We're not trying to deliver that SA. So we are hitting plano in the non-dominant eye for they're not plus a quarter, but plano. Just a little bit of this, believe it or not, as silly as it sounds, quarter diopter. And then we're going to really see what that sometimes that multifocal cornea can do. In many of our RK patients, we're hitting distance with this formula and they are reading well and they are happy as a pig and you know what? And we're done. We are done. Um, with Tina, I'll be playing with that too. But myopic LASIK can work the same way. That's really very typical where you have that multifocal cornea is working for you. You don't use a lot of disparity. Patient's doing great, multiple ranges, you're done. If you don't, and you've got a perfect cornea, you know, I, I'll say this, I'm a cornea nut. I'm looking at, so is Brian. If you're going to fail, you're probably going to fail from not looking at the topos, not looking at the corneas. Watch those corneas. If you got a very regular amount of astigmatism, everything looks great. The MAC looks great. We do MACs on everyone, do RNFLs on everyone. I do deliver that negative SA on the first treatment more times than not. Um, Even with someone that's not used to monovision, it's not a lot of disparity. The patients will usually adapt to that. They're going to get a better range of vision, very higher satisfaction. That's me. I'm going to do that. I've had good success with that.
Mhm.
Otherwise, if they're not happy with that little minus 50, then we'll do these small incremental jumps beyond that as long as they're tolerating disparity. Speaking maybe a little bit more to that fourth adjustment, sometimes I use it to back out of that. If you went too far and you want to go back a little bit, that's sometimes when you open up a fourth and go the other way because your disparity is too much. Just another little comment there. And that's worked also well for me. Very rare as well. Don't often do that fourth adjustment. It's rarely needed. But
Yeah.
that's what I do. So our targeting is there. Um, if you have a cornea that you look at and it's got EBMD or it looks funny, please don't deliver the negative SA.
Mhm.
And please be very careful with your disparity. Um,
Yeah.
just listen to a guy that's done thousands of these. Don't do it. And if you do it carefully, you know, and don't be afraid to back out of it. Do a little. If they hate it, if their distance immediately goes, oh, my distance is terrible, you better back up. You better back up. You're going to be in trouble because those are not patients that are easy to enhance and they have very unreliable refractions and they're just tough patients. So that's
Yeah.
just word to the wise.
You're 100% right. And so just for anybody who's the non-doctors out there who are listening, what you're talking about, the negative spherical aberration. So you have the ability to titrate that a little bit with the
Yes.
adjustments. Aberration again is typically an undesirable thing. However, in this setting, it's desirable because we can extend depth of focus. But it only works well if you've got a perfect eyeball. So
Yep.
yeah, if you're less than perfect, I mean, if you have some irregularities on your cornea, severe dry eye, if you've had LASIK before, I don't trigger that because we don't want to add more noise to your system. We don't want to create more starbursting or halos. So, but we have the ability to do that on the first adjustment. But Eric, exactly what you said, man. I mean, the targeting logic that you use is exactly what I do. The dominant eye, we switched to doing plus a quarter. Being a little bit on the hyperopic side is not a bad thing. If I'm anywhere from plano to even plus 50 and they're tolerating it okay, that's
Yep.
that's considered that's a hole a ball in the
Yes.
hole. That's a hole in one. We're happy with it. We're gonna lock that in. The non-dominant eye, that's where the time comes from because we're playing with it, but again, simultaneously letting our patient kind of catch up, let their visual system understand the new information that's being thrown at it. But exactly what you said, that's exactly how my brain works through it as we're going, and that's again where the art comes in. And I think the true team aspect of this whole process is the patient. Their feedback. They're
Yeah.
telling you what to
Yes.
do. You're just telling them what makes sense and if we can do it. But
Yep.
they're the ones guiding this whole thing, which was what makes this super, super cool and super fun and rewarding for all of us. Well, hey guys, we're coming up on an hour. I want to say thanks, Eric, Brian. Thanks for joining me. That was an awesome conversation.
Yeah.
Thanks for everybody for your questions.
Yep.
This has
Loved
been
it.
recorded. It will be on the peer-to-peer.academy website. So if you want to rewatch it, share it, go ahead. And finally, probably most important thing, Go Lions. We'll see you
Go
guys in
Bucks.
February.
Go
Thanks
Bucks,
so much,
baby.
Nick. Go Pack, go, baby.
Baker.
Yeah. Thank you guys so much for having us.
Thank you. That was
Have a good one,
great.
Nick.
That was a
Thanks for
really
having us
great
again.
back and forth
Nice,
there,
okay.
Nick. Good job.
Yeah.